Will we turn into zombies after we take the vaccine?
Well, so it's a great question. So
Great.
It's not a great question.
it is a fantastic question.
It's not.
So
It's a question that we're all on the edge of our seat for.
That's okay. That's fair. Hi, you're listening to the Reinvention podcast. I'm Aaron Anderson, here with Elizabeth Byland.
Hi.
And we're talking with Dr. Alan Dow today.
Thank you for having me.
Hey, thanks for being here. So, Alan, you have a really interesting title. So before we go any farther, it's about an 8-page title. What is it exactly?
Assistant Vice President of Health Sciences for Interprofessional Education and Collaborative Care.
Okay, that's not as long as I thought it was.
He definitely summarized, I think.
Yeah, I think there's a lot of things. You're the Ruth Pearl somebody.
Yeah, so I have an endowed professorship. I'm the Ruth and Seymour Perlin Professor of Health Administration and Internal Medicine, which is a professorship that spans 2 different schools at my university.
What are the schools?
So it's Health Administration in the College of Health Professions and then Internal Medicine in the School of Medicine. So it's meant to do interdisciplinary work.
Okay. And you're a medical doctor, but you also have an MSHA. What is that?
So that is a degree in health administration. So part of that Perlin professorship, I think part of how I got it was I have this health administration degree, which helps me think about systems of care and how we develop programs to change them and make them better.
Okay. So you're not just a doctor, but you're also you have some expertise in dealing with systems, putting together systems to help people in different ways.
Yeah, a lot of what I feel like I do from day to day when I'm not taking care of patients is program development. So developing new programs to try to fix some of the problems we have in our healthcare system.
Okay.
Wow.
Yeah. There's no stress there.
No, none.
I didn't say I was good at it.
So I want to talk to you specifically. You do so many things, and you and I have been friends and colleagues for many years. And I want to thank you for all of that. In spite of the fact that you don't like me that much, I enjoy being around you very much. But you do such a broad span of things. We could probably talk for a year about all the different things that you do to help. There are 2 specific areas I want to talk about today. And the first one is the most pressing. I know you're not an expert in infectious diseases, but you are a doctor, and there's a pandemic, and there are now some vaccines out there. How excited are we, and how much should we temper our expectations about this?
Oh.
Yeah, so we should be excited in that we can now start to feel like the end is in sight.
Yes.
Oh, thank goodness.
I think by next summer, we can start to think about life getting back to normal.
Okay. It's still a long time away. It's fine.
Yeah.
When you say normal, do you mean normal, like it was, or is it all going to be new?
Well, we'll have to see because we're not sure about what will happen with COVID, and I can talk about that in a second. And then we're not sure how effective the vaccine is going to be, and part of it being effective is how many people will take it, and so what will the world look like? But between now and the summer, we should have an opportunity for everyone who wants to get vaccinated in this country. And so at that point, if you've had the vaccine, and if the vaccine turns out to be as effective as it seems like it is so far, you can feel pretty good about starting to see friends again in person and not wearing your mask as much and things like that.
Are we going to be able to go to movies?
I think so. Yeah, I think that's probably reasonable to think about that. But I don't know if movie theaters are going to look the same way. I mean, maybe they won't fill as much occupancy.
Will we turn into zombies after we take the vaccine?
Well, so it's a great question. So
Great.
It's not a great question.
it is a fantastic question.
It's not.
So
It's a question that we're all on the edge of our seat for.
That's okay. That's fair.
So the 2 vaccines that we got data about first, the Moderna vaccine and the Pfizer vaccine, are made with messenger RNA technology.
Oh, no.
Yeah.
I don't know what that means.
Science class.
I
Yeah.
don't know what that means.
So it's a certain bits of protein in the cell that are different than DNA. RNA is sort of made from DNA in most cells. It gets complicated pretty quick.
Okay.
But we have never had vaccines that are made from this technology. So these are the first 2. Yeah. And so.
Oh, for real? These are not only is this a novel coronavirus, but these are novel vaccines.
Novel vaccines. Nobel Prizes will be won for making these vaccines. And the fact that they were made so quickly is just remarkable. It's really a scientific feat. And because of that, we aren't sure if there will be some unusual long-term side effects to them. The most likely thing is that they may not be as potent as we hope, and so that people may need to get revaccinated in 6 months, a year, 2 years, who knows?
Well, we do that with the flu.
We do, yeah. And so the reason we revaccinate for flu is a little bit different than with the novel coronavirus, but there's still a lot to learn here, and so we're at the beginning of the end, but I'm not even sure what the end is going to look like.
Right.
I hope it's not the zombie apocalypse.
Well, so zombies is not actually as bad a question as I thought, because it is an interesting. It's probably not going to be zombies, but we don't know exactly.
We don't know, Aaron. We don't know.
Yeah,
I'm fairly certain it's not zombies.
Well, I'm fairly certain Elizabeth has had better questions than you have so far.
Oh, nicely done. Yes. Nicely done. All right. So let's the main thing I want to talk to you about is this idea of interprofessionalism, because it's a fascinating subject to me, and for this podcast is about reinventing yourself and finding jobs between jobs. And interprofessionalism is intriguing to me because I'm not sure why it's not the default. Can you describe briefly what interprofessionalism in healthcare is?
Yeah. So let's do some definitions first, because I think that will help. So professions are generally fields in which there's expertise, and they're often supported by licensure and guilds and professional societies and things like that. And there's usually a certain body of expertise within those professions.
Guilds, like in D&D?
It could be. So a thief is a profession, a magic user, if you want to go there.
Okay.
And if you're a thief magic user, well, then that just gets really exciting in the game.
I feel like we're going back to zombies, guys.
We're you know what? You set the tone. We're just going to go with it. So, but there are guilds. So profession is an organized group of people who all do the same job.
Sure. Yeah.
Okay.
And there's even groups within professions. But the idea is that I'm a doctor. I went to medical school, which was specific doctor school, did a residency in internal medicine. So that's sort of a subgroup of doctors, as I did internal medicine instead of obstetrics or psychiatry. Okay. And I have my meetings, and I have my licensure, and I have my colleagues in my profession. And so that's really important, because you're trying to develop that individual expertise that you need as a doctor or a pharmacist or a nurse or an occupational therapist or whoever is on the healthcare team. But it turns out that when we actually go to take care of a patient or of populations of patients, you're not just working as a single profession doing that. We know you're working as a team of different professions. And so interprofessionalism is that idea of how we bring the expertise of those different people on the team together to best take care of a population or a patient in front of us.
So this is what I want to ask you about, because it sounds like that makes perfect sense. So essentially what you're saying is groups of people who have different jobs learn to talk together about the patient in order to make the patient's life better. Is that right?
Yeah.
Why don't they do that anyway?
Yeah.
I mean, so for instance, if anyone here has ever been in the hospital, there'll be a group of people who come in, and then another group of people come in, and everyone will ask you questions, and then you'll go to see your primary care physician, and maybe you see a specialist, and it seems like nobody really talks to each other. Mm-hmm. Why is interprofessionalism not the default setting?
Yeah. And it's because all of our structures are set up to sort of pull those healthcare teams apart. And so when we teach this to our students at the beginning of their academic careers, they have that same question: why is this so hard? And then when they go into the environment, they see why it's so hard, because we train as health professions in our separate silos. We develop our own language. We sit in different places when we do our work, whether it's the doctor's room or the nurse's station or the therapy unit. We get paid in different ways by insurance companies. And so we're not paid to work together. We're paid to sort of do our separate work, and the funds flow in different kinds of ways. And we're rewarded in different ways for the work that we do. So there's lots of things that sort of pull us apart. And in addition to that, there's the sort of human nature of tribalism, where we feel like we are part of a tribe. And so I very much take that professional identity of being a doctor, and it's important to me. I'm proud of being a doctor. I worked really hard to be a doctor. Same thing, people that are nurses or pharmacists. And so when you see that other person across the way from you that is part of that other tribe, it's not instinctual to go over to that other tribe and sort of start to make friends with them.
Right. And say, what do you think?
Yeah. And I see it in medicine between, say, I'm an internal medicine doc, but internal medicine doctors and surgeons. And you've probably heard about sort of, internists making surgeon jokes and surgeons making internist jokes. I mean, it's
There's the whole TV show Scrubs was about that.
Yeah, exactly. And so it's all true. What we have seen is that there are progressions of expertise in doctors where when you go through residency, you finish sort of with a basic competency in being able to be a doctor. And then you spend the next 2, 3, 4, 5 years mastering your craft and seeing a lot of patients and being able to be an expert in how you take all that knowledge and without a lot of effort be able to take care of patients. You learn how to do it efficiently and to develop all those sort of cognitive tools to be able to do it very quickly. But then it takes another 10 years or so after that to learn how to work with the team and lead or follow within the team to be able to do it effectively interprofessionally. And so it really is a mid-career skill that most people learn without training and support to become interprofessional.
Wow.
Okay.
We're trying to accelerate that. That's really the work of interprofessional education, is accelerating that learning.
Oh, there's a siren going on.
Yeah, I got to go.
So, is this idea of interprofessionalism, is this unique to the healthcare profession, or are there parallels that can be drawn for corporations or people who are just working on their own?
Yeah, so great question. So,
See, Elizabeth, that was a great question.
I was just being nice.
I was trying really hard to come up with another really good question because my zombie question apparently was a fail right out of the gate.
Oh, no. Oh, you won that one.
So interprofessionalism is a subset of interdisciplinarity, which is the idea of bringing different disciplines together. So Aaron, you and I, and Elizabeth and I have also done work where you're bringing expertise from the performing arts into healthcare. And so that's an example of interdisciplinarity rather than interprofessionalism, because you're taking a different type of expertise and bringing it together with another type of expertise to try to solve a problem. And in the case of all of us, teamwork, communication, collaboration. And we see that with other things like science. You may take someone who's got statistical expertise and combine them with someone who can take pictures of little tiny parts of the cell and come up with a research proposal where you're using those two skill sets to do some groundbreaking science. That's interdisciplinarity. And if you're in the business world, you may have someone who's got expertise in finance while someone else has expertise in innovation and design, and you come together and you make a new company and perhaps develop Google or Apple or something along that line. So interdisciplinary is everywhere around us. It's really hard, and it faces some of those same barriers that we see with people's professional traditions and their tribalism getting in the way of interdisciplinary work.
It sounds like trust is really crucial in any kind of interdisciplinary study or collaboration, because you're really having to trust that this person is bringing their best self to the table and you're bringing your best self to the table, and together trying to make something else better. Is that right? Is that what I'm hearing?
Yeah, that was such a great question.
See, now you're just rubbing it.
So I think first you have to master your own
Yeah.
domain and be sort of expert in those skills, and then you have to learn about what other domains can do and how you sort of fit in. And so there's a connecting there that needs to happen in terms of understanding that other profession or discipline and how you might sort of fit together. And as you develop that awareness and insight into each other, you do start to build those communication patterns that eventually lead to things like trust and openness and the kinds of things that we see in any great relationship where you're able to work together.
So it really, I like this idea. It's a mid-discipline skill. I mean, it's a mid-career thing. It's not a thing you do right out of the gate.
Mm-mm.
Well, and that's traditionally been true, but I think one of the challenges is because we know interdisciplinarity is so important, that how do we start to do it earlier and earlier in people's professional careers? Sometimes I think about it as we're in a world where there's these big mountain peaks that are the different disciplines, and the deep knowledge that we have is those mountain peaks of these different areas. So you've got the biology peak, and you've got the accounting peak, and you've got the medicine peak, and you've got the improvisational theater peak. But in between are these valleys where those things have not been brought together, where we haven't necessarily developed the knowledge and expertise societally that we could have if we'd combined these things together.
So how do you train it? How do you go about doing this?
Yeah. Well, so I think it's interesting to think through those steps that I mentioned about how people start to interact together. And so as you understand your discipline and what it's about, I think it's important to start to learn about other disciplines, because through understanding those other disciplines, you start to see where your discipline fits in the world. And so what is its place in society? What does it have to offer? Where does it fit? And so you end up with this broader awareness of where things are. So that's one is that understanding of the different in a sense roles of professions and fields within our understanding of the world and our constructive knowledge. And then second is those skills of listening, connection, understanding, so that you can understand what other disciplines can bring to a problem, and then also understand what your discipline can bring to that problem and how you describe that to other people. So sort of those building relationships kind of aspects of things.
So you're not waiting for problems to come to you. You're sort of looking across the mountain and seeing, oh, I could make their lives better.
Yeah, and I think it's a little bit of both, because I do think it helps to have a problem to collect around. But for example, if you take any of the sort of existential threats in front of us, the COVID pandemic or climate change or economic inequality, you could have a conversation with someone that has an expertise in a discipline other than yours and say, well, what does your discipline think about this problem? What would you do about this problem? What would you have to offer? And I think that kind of curiosity and those kind of conversations can lead in all sorts of fun and interesting directions.
How do you do that though when healthcare is just forever changing? I feel like it's always evolving. There's always something new to learn about your field, another field. I feel like it's so tough maybe to be an expert in your own field when it's just always changing.
Yeah, how do you train this? Is there a curriculum involved, or do you just say, hey, everyone talk to each other?
Yeah, Alan, how do you do this?
How do you do it?
Come on, Alan.
Come on, man.
Come on.
Yeah. Well, so I think there's two questions there. So I think Elizabeth's question was about when you have fields that continue to evolve, what do you do? And you do have to keep up with your field.
Yeah.
But I think the beginning part of your learning is you understand what the contours of your field are. You understand what is known, and equally as important, what is not known. And we continue to nibble away at that slice of stuff that is not known in medicine, and we learn more and more. I mean, we're not, worried about the evil humors, and we're not using leeches too often these days.
Or zombies.
Yeah.
Not worried about them, Elizabeth.
Not yet.
Yeah.
Not yet.
Yeah. And so I do think there's learning there, but frankly, as fast as medicine evolves, and it certainly evolved very quickly with the COVID pandemic, it wasn't stuff that was hard to keep track of. There's been probably 10 or 12 really important COVID studies have come out, and I've read all of them, and it's not that hard to read 10 or 12 scientific papers when you've read a bunch of scientific papers. So I do think you have to keep track of that and continue to work on your expertise in that way. But that's not the hard part once you have mastered your craft. But I think creating venues. So a lot of what I try to do is create venues where people from different disciplines can come together and have conversations and start to think about problems and how we might leverage the different kinds of expertise to try to solve problems. And it is hard work because it's unknown territory by definition. There's not a way to do that. But on the other hand, it's very important work. And the difference between taking that mountain of medicine and adding a little bit to the sides versus starting to fill in some of the valleys in between, you can make a much bigger difference in that interdisciplinary work that you're doing.
It's a very selfless way of existing too, isn't it? I mean, even just like what you just said, knowing that by creating a space for individuals to come together and learn from each other and learn with each other, I mean, and that's because you notice that there was perhaps a void that needed to be filled, or perhaps that there's just sort of this wall between these professions. And then by saying, well, here, let's create a space that allows us to come together and have a conversation. I mean, that's really incredible. But that's also what I think interprofessionalism is, isn't it? It's being able to have those conversations. And in order to have those conversations, you also have to have the spaces in order to have those conversations. And that's a hard thing to find. But then you have individuals like you that is very purposeful and intentional in creating those kinds of spaces for others. Is that right? Is that what I'm hearing, Alan?
Yes. Yeah. I mean, I guess I got struck by the word selfless when you said that, because I don't think of it as selfless. I think of it as I've always had a wide range of interests and things that I am interested in learning about. I'm a curious person, and I like to read lots of things and watch different things and just be exposed to lots of different things. And so I am wired in that way that I am interested in the spaces in between things. Because I think that's where we can learn a lot. And so I think it's more of a challenge if you're not wired that way, because there are people that want to become the expert in this one thing. I have colleagues that want to become the expert in this one tiny cell in the heart, and that will be what they spend their life doing is trying to understand this one tiny cell in the heart. And I don't look at the world that way.
Right.
I feel like there's so much out there to experience and be a part of, and I like to be a part of as much of it as I can.
See, I think that's selfless. I think there's two ways of looking at it. There's the idea of, you're the only one that's driving the car, and you're going to drive your car as fast and as hard as you can because it's just you and it's just your car and it's one road. Or you look at it like, oh, okay, there's other cars on the highway, and these other vehicles are also determining, the direction that I'm also moving in. And so it's kind of this very cool, I think, way of existing. It's understanding that you matter and what you're doing matters, but also you make up, a much bigger picture, and there's lots of moving pieces to that picture. And the way for you to, I guess, excel is also by learning from and with other individuals, right?
Yeah. I mean, I think we are part of a complex system as people, or as living creatures on Earth, or as a planet in the galaxy, however you want to look at it. And so, I have always enjoyed the moments of wonder you have where you look up in the sky and see all the stars at night and things like that. And your example of watching traffic, I mean, I think it's a great one because there's a lot of complexity. There's all these individuals making decisions to navigate traffic in different kinds of ways. And what's interesting to me, you're right, is not that individual car or driving my individual car. I hate driving, but I think it is fascinating to watch the traffic, move through. Yeah, it's fun, because you see what happens.
Let me go back to this word selfless, because it's interesting. I've been reading Clayton Christensen's "How Will You Measure Your Life," and he points out something in there that incentivization is one of the things that we do to motivate people, but perverse incentivization can really derail a whole bunch of different stuff. So what you're talking about, the guy, if you just want to study the one cell, right? Or if you're in business and you just want to, be the best accountant you can, or the best whatever, the best musician in your band or whatever, if you stay in your lane, all the incentives are for disciplinarity. All the incentive structures are set up to be good at your one field. There aren't really that many incentivized structures other than the intrinsically motivated, that sense of awe, and the people who want to wander off the path. That, those are individual motivations, but the systemic incentives are really to stay in your lane.
Well, I'm not sure about that. I think so. Self-actualization is probably the biggest incentive, that you feel good about what you do, that you've accomplished something, that you have lived a life according to your personal values. And so the idea of self-actualization, for whatever that means for you, and maybe it means, incredibly detailed study on one cell, or maybe it's a wide range of experiences where you do different things. And I know, Aaron, for you, that's you're more like me in that regard than studying one cell.
Oh yeah. Anyone who puts something shiny in front of me, I'm going to go that way.
Yeah. And I think that motivation, that incentive, is much stronger than the typical either reward or disciplinary type of things that you can have to incentivize people. We actually know that positive and negative incentives, these external incentives, are not particularly long lasting compared to internal incentives, and it's really hard to teach how you transfer that external incentive into an internal incentive, to say your children, so that they start to, want to put their dishes in the dishwasher or clean up their clothes after
My
themselves.
kids will never want to put their dishes in the dishwasher. That is, zombies will come before that happens.
Yeah, but at some point they will, because you're not going to walk into their house, 40 years from now and there'll be dishes in the sink.
I will be very happy to walk anywhere 40 years from now.
Yeah, well, yeah. But I think it's people do learn how to do these things, and how do you create a structure. And so with something like interdisciplinarity, it's how do you get people to be open to the concept and start to see the value, and so that when they progress into their careers, they're willing to learn about others and cross cultures and do all the stuff that is the hard work of being interdisciplinary.
So let me pivot for a second, because speaking of doing things for intrinsic motivation or trying to self-actualization, making the world a better place, you also, so speaking of all the things you do, you've also been hosting a webinar, a web series to help physicians and healthcare workers in Virginia deal with COVID. Is that right?
Yep.
And this is not part of your. You're not paid for this. This is you're doing this for a different reason.
Yeah. I'm not paid for it. So right at the beginning of the COVID pandemic, our CEO said to me, and I part of what I do is I help run our continuing education efforts at VCU. Said to me, we should do something around COVID. And I was like, that's actually a really great idea. And so that was on a Thursday. And so on, I think Tuesday, we did our first episode, and this was in very early April or late March. And since then, we've done over 60 episodes.
Wow.
We were doing them every day for the beginning because there was just so much uncertainty about what was going on. But different experts, we would have physicians and nurses and pharmacists and people from the health department, a variety of people come talk about COVID and different aspects, psychologists, and tried to go through all the different aspects of what was going on with COVID. As time went on, and we spaced them out, so that now we do them once a week, and we actually are doing some non-COVID topics as well, because the audience has really enjoyed it, but we don't have as much to talk about with COVID. So we do COVID about once a month, and then we do about 3 shows that are of different things. But it's a half-hour rapid back and forth interview format where I host and I interview an expert about a topic.
That's cool.
That's really cool.
What are some of the things that you've learned from doing that?
Wow, great question.
Ha! In your face, Elizabeth. Huh?
And I'll put a tally next to your name. It's fine.
Listen, I'm as surprised as you are. Yeah, so I think we are facing just this very unique challenge. I mean, people try to compare it to the 1918-1919 influenza pandemic, but we're in just such a different place in the world. We're so much more global. Media is different. It was originally called the Spanish flu back in 1918, 1919, because Spain was the only country that was honest about what was going on, because everyone else was fighting in World War I. And so I
did not know that.
Yeah. So we've been much more open about it and really understood things. And scientifically, we're just in a completely different spot. I mean, that's pre-penicillin, if you think about where we were in the first flu pandemic. So watching how our world responds to this pandemic in such different ways than anything else that we've ever faced, and what we do in those situations is something that we can learn from it. So let me give you an example. So if you look at the countries across the world, the United States has done the worst in terms of responding to the pandemic. Probably followed Brazil and India are probably number 2, but they're a distant second behind us.
You mean in terms of just number of cases, or in terms of deaths, or in terms of what? Yeah,
cases, deaths.
All of it.
Yeah. There's some small places that are probably worse. Luxembourg is probably not done as well.
Yeah, screw those guys.
Well, it's a small number, so it's hard to really study. And there's places where we don't necessarily have great numbers. But all that being said, here we are in the United States, the wealthiest country, the country that in many ways has the best healthcare systems, but also the greatest healthcare inequities in the world. The country that has been the source of all sorts of wonderful innovations and this great experiment in democracy and multicultural society and all these kinds of things. And we've really struggled with the pandemic in a way that other countries have not.
Mm.
Why?
Well, so people talk about the 3 waves of the pandemic, and I think they each hit at different challenges in our U.S. society. So the very first wave was New York City, somewhat Seattle, and it was us not understanding the virus and it coming into places that were these big international hubs and spreading very quickly before we really understood what was going on. I don't know that the United States could have done much about that. Maybe we could have been a little bit faster to act, and we were a little bit slow politically and from a public health point of view to act.
Can I ask you a quick question on that,
Yeah.
Alan?
Only if it's a good question.
Well, I don't know. But were we slow, or was it that we also just kind of had like our blinders on? Like, that's not happening here. So instead of caring about it, we'll put our attention somewhere else. Do you think, did that have anything you think to do with it? And maybe that's just a whole other different can of worms and different, just different ball game. But I feel like kind of going back to what we were talking about before with just like this idea of just selflessness. And there's also, I think, something in this conversation alone that is an example of that, of what happens when you're only focused in your lane and only staying in your lane, and then the detriment that sometimes that can cause.
Yeah, that is a great question.
That is a great question.
Thanks, guys.
I will give you that one. That's a fair point.
I was sweating bullets before I asked it. Okay.
Yeah, well, and I think it's complicated, and
Yeah.
we're going to have to see what the historians say. Let me take you through the 3 ways, because I think your point
Okay.
actually becomes even a better point as we go through this.
Ooh.
Because I think that first wave, we probably could have done more. If you look at what happened politically, we were slow to act, and we didn't try to understand the problem and act in the way that we could have. It's tough to compare because you end up comparing things like the Ebola outbreak in Africa and our reaction to that compared to this pandemic response. And the historians are going to have to sort of sort through that. But it's challenging because this is a different disease, and it's tougher to contain than Ebola because it transmits more easily, and people are asymptomatic when they can have it and can spread it. And so there's challenges. But that's the first peak. And so maybe we couldn't have done anything about that. It's tough to say.
Sure.
But
that's in major cities, and we're caught unawares. So that's the first peak.
Yeah. And then our second peak was in June or so in Texas, Louisiana, Florida, places like that. And there it's again big cities, but these are not the big international cities like New York. I mean, they're still international, but they're bigger. And they're places that are not necessarily adhering to social distancing and masking in the same kind of way. And so you see our polarization of how we think about science and stuff start to manifest itself in these issues going on in these cities and basically red states, if you want to think about it that way.
Right.
But we got our arms around that. People learned and started to say, okay, this is what we need to do to sort of prevent that. What's really fascinating and unfortunate now is that the pandemic is really a rural America problem. And so you have places where people felt like it didn't really affect them because they didn't have a lot of neighbors that had been affected, that didn't believe in masking and social distancing and didn't need to because they were, in a sense, protected because of the population density for a while. But now in these rural areas, they're having huge amounts of COVID in North Dakota, South Dakota, Idaho, Utah, Iowa, Minnesota, Nebraska, places like that.
Right. Or in
Missouri.
rural Virginia right now.
Yeah. Yeah. And it's starting to move into rural Virginia and places like that. And these rural hospitals fill up, and then they start to push patients to the urban areas where there is still, enough COVID to make things challenging. And so we're seeing the rural urban divide really start to be manifest in how much of these rural centers depend on these urban centers for their healthcare and other things as well, but particularly their healthcare to be the center of the medical system for these states that have lots of rural areas, and Virginia's an example of that.
So they're not really three waves of the disease. They're three sociological impacts.
Yeah. And that's the trouble, is that when you look at those national curves, you miss that this has actually been three different kinds of activities going on.
But see, why? I think that's the part that I just can't wrap my head around, is that we missed it, and we missed it the first time or the second time or the third time. And so then when I ask, okay, then why did we miss that? And I feel like I keep going back to this same, the same idea that part of it is because we're just so focused on only what we can see, only what's right here, only being an expert in my day-to-day life. And if I don't see it, then it doesn't exist.
Well, and in America also, we're not good at trusting experts.
Yeah.
Right.
And then that goes back.
China and other places. I mean, in Asia, their response was much more robust, and it's a much more conformist sociological system. And so people did what they were told. And in America, we're not so good at that.
So, Alan, may I ask you another question?
Only if it's good.
Well, can I answer that? What you just said first?
Yeah.
And
okay.
this may be your question, but yeah. So China goes about addressing the pandemic by saying, if you're caught in the street and you're not supposed to be there, you're going to go to jail, and they use drones to track people and things like that. That would never fly in the U.S. and I'm glad it doesn't. That's not what we want in this country. So China's a place to look at and try to understand this. But more interesting to me are places like Vietnam, lots of countries in Africa, New Zealand to some degree. Places
that are not as authoritarian.
Not authoritarian, and say New Zealand in particular, not authoritarian. Vietnam,
right.
not as authoritarian. And so, but they have more of that deference to expertise that you're talking about, and more of this sort of developed public health. It's not just the public health system, but the culture of public health, where if the usually it's community nurses show up and say, okay, you need to do this because this bad thing is happening. The people are like, okay, we're going to do this. Whereas here, if some community nurse went to a small rural town and said, okay, everyone needs to wear masks and not gather together, people would say, oh, that's ridiculous.
Yeah.
So it is a different kind of way of doing things. And selflessness is an interesting way of thinking about that, in that our personal independence overrules that idea of thinking of what's important for a greater society.
Yeah.
When I was in the military, it was the difference between rights and responsibilities. You have the right to do something, but there's a responsibility that comes along with it. And I just don't understand why we don't have the conversations here. You have a right not to wear a mask, but there's a responsibility to wear one.
Mm-hmm. It's taking care of the we before taking care of the me.
Yeah, we're not good at that.
No.
Yeah. Well, and we have other health crises going on in the U.S. I mean, we've
Sure.
sort of forgotten about the obesity epidemic, but there is an element of pleasure seeking with eating in terms of how we approach nutrition and food and exercise and things like that here, that I think is in some ways a manifestation of the same issue, and that we seek out that pleasurable thing in the short term, not worrying about the long-term consequences.
Are these things you talk about on your webinar?
We talk about COVID. We don't talk about obesity. We will talk about obesity. We haven't talked about obesity yet. And frankly, we're going to sort of a deeper level of what does it mean to be in modern society in this conversation than we do on my webinars.
Yes.
All right. So I'm not really sure where to. I've enjoyed this. I don't want to get too far in the theoretical weeds. I've really enjoyed talking to you just about the really specific things about interprofessionalism and the work on the webinar. Do you have any stories? I'd like to sort of end with, instead of talking in broad strokes, is there anything you learned specifically from either your work in interprofessionalism or in this webinar? Any stories that you can share that are in any way, shape, or form, indicative of larger trends, or anything stand out? Have any experiences stood out for you as sort of aha moments?
Oh, wow. That's a great question, Aaron.
See?
It's another
It's a hard
tally.
question. It's a hard question.
Well, I think there are lots of stories, moments when you change the way you think about something. But I'll tell you one from my distant past, and I'll tell you one from my very recent times.
Ooh, it'll tie them together in a nice, neat bow. That's good.
Well, and I'm not sure that they'll tie things together, but I think that they sort of examine where we are. So the first was when I was a brand new doctor. So I'd done my well,
A baby doc.
brand
You were
new
a little doc.
attending doctor. Well, so I'd done medical school and I'd done 3 years of internal medicine residency, and I was now working as a hospitalist.
Okay.
And so I was about 3 or 4 months into being an independent practitioner by myself, taking care of people. And I had a patient who had multiple sclerosis and had an infection. And so multiple sclerosis is a disease of the nerve, spinal cord, brain, where you develop weakness and inability to sort of move as well as you want, and among other things. And if you get an infection, it can make all those symptoms worse and can make it life-threatening. So this woman had this infection, was weak from it, was in the hospital getting antibiotics. And I went by to see her, 7:30, 8 o'clock in the morning one day, and she was doing worse. I think she'd maybe come in the day before and was now starting to do worse. And so I was there working with a nurse who was relatively new at being a nurse too, but clearly someone who knew what was going on and how things should work. And we were both by her bedside taking care of her. And I had this list of, 20 other patients that I had to be taking care of that day. And we came up with a plan to stabilize this patient, but I was still worried about her and thought she might need to go to the ICU. And I had the ICU doctors coming to see her and so on and so forth. And the nurse said to me, "What are you doing?" I was like, "Well, I'm here with the patient." She's like, "You should need to go see all the other patients that you have here." And I thought, well, here's this patient in front of me that's my responsibility, that's sick, that I need to be here at the bedside and be here for her. And she's like, "I've got this. You go see those other patients because they need you too." And so I did. And at some point I had to come back, and the lady went to the ICU and was there for a couple of days and came out of the hospital, or came back out of the ICU to my service. Then I eventually sent her home. She did fine in the long run. But it was a very important lesson for me about part of being a interprofessional collaborator is you have to take that leadership ball that you have as a doctor or a leader or whoever and hand it over to somebody else and let them be the leader so that you can go and do the other thing, whether it's be a follower or in this case, see other patients. And so I very clearly remember that. And I remember Mary, who I'm still friends with, the nurse, and that moment of where I said, "Oh yeah, my job is not to."
Well, you wanted to do some emotional labor, and she was like, "There's more people. With people who can do that, you need to go do other things."
Yeah. And honestly, my expertise, I needed to spread it around to where it was needed, and at that moment, it was not needed at that woman's bedside, despite how sick she was.
Huh.
Yeah. So I think that was.
Yeah, that's not an obvious lesson, right?
Yeah.
Not as a human.
Yeah. And I think it's one of the things I look at back as the making of Dr. Dow, as I learned about things, was that lesson.
That's a scene in the movie, The Making of Dr. Dow.
Yeah.
Right, that's one of the pivotal scenes.
Yeah, that's where the zombies come in.
But see, I think again that goes back to trust. Trusting that this moment is okay for you to move, not completely away from, but it's okay for this moment to be given now to somebody else.
Yeah.
To handle.
Yeah, that's not easy to do.
That I can't imagine.
Especially you are a very naturally empathetic person, and so I would imagine that every instinct that you grew up with as throughout your entire life was stay here with this patient for a little while.
Yeah. Well, and when you go through high school, college, medical school, I mean, you're always in a leadership position and doing pretty well, and you don't learn that leading also means letting others lead.
That's good. All right, so that's a good story. So that's one scene in our movie. What's our other scene? What's our more recent one? I like that one. That was good.
That was really good,
Alan. That was a very good story.
Well, and this I think will then call back to some of the other stuff we've talked about. And this just happened to me a few months ago, and it's an example of where I still struggle as a physician and try to be the best doctor and best teacher that I could be. So I was taking care of a patient, and this person had significant anxiety issues and health problems relating to the alcohol abuse that they used to treat the anxiety. And so there was a problem there. And so now in my career, I try to get to sort of the underlying problem of, okay, how do we really help this person? I can treat the complications of their alcohol use as best I can. And I know what the books say to do that, but you got to sort of dig deeper to the next level set of problems. And so we're there on rounds, and it's just like you see on the movie. So I'm there, and there's a resident and a couple of interns and a couple of medical students and a pharmacist and some pharmacy students, maybe the nurse. So there's like, 10 or 12 people. In your world, it'd be like a small little theater of people there watching, me interact with the patient. And usually I'm not the one that's the main character. I let the residents kind of, run what's going on, but I'm there and I will often ask a follow-up question or two of the patient of things that I care more about. And in this case, I cared more about why was this person having such anxiety?
Mm.
And so this individual said to me when I asked, they said it was because that their child was engaged in a same-sex relationship and had gotten married. And
that was causing anxiety?
Yeah.
Okay.
And I, to this moment, don't know what the right response is there, because we live in a world where, I believe in, I think both of you believe in, that people should love who they want to love. Yet I have patients that have different value sets than I do. And these value sets are leading to them having health problems that I'm trying to help. And
So you're dealing with somebody whose value system is anathema to what you believe to be morally right.
Yeah. Yeah. And I have this duty, this responsibility to try to care for them and help them be better. And it's very easy for me to say, well,
stop that.
Same-sex marriage is okay. Why
Right.
you should, you just need to accept that. But that's not going to help this patient.
Wow. I don't know what you do with that. What did you do with it?
Yeah.
Well, and like I said, I'm still struggling to this day, because there's helping the patient, and then there's also being a good educator for my residents and my students, some of whom may be in same-sex relationships, I don't know,
Right.
or have a sexual orientation to the same sex, same gender.
Or just, just believe that, people are people, and
Yeah.
that this is
Yeah.
in some way, this is like, so this was anxiety brought on by something that is not actually a problem. It's in my mind, this is an invented issue that is causing this anxiety, that is causing these side effects with alcoholism and all that sort of stuff.
Well, see, that's easy for you to say.
Right, but that's what I'm saying. That's what I'm saying. In my world, that's exactly what I would see it.
Yeah.
But in some sense, it's also like talking to somebody who's smoking 3 packs a day. You mean their health is easily changed by something that you believe is wrong to do anyway. Right? But right now you're dealing with the fact that this is not specifically a health issue. This is some sort of you don't want to because you wouldn't have the same struggle if they were smoking. You wouldn't stop yourself from saying, you may consider, like you would do motivational interviewing and say, why are you smoking?
Yeah. I think to bring this back around, I mean, this is one of the challenges with cross-cultural or cross-discipline work,
right? Is
that there may be an ugly side to this that forces you to try to figure out, how you're going to engage in that conversation. And then in my case, how I'm also going to then role model how we should do this with, the learners that are with me, the residents and students that are with me that day. And I don't think I did a good job. It's interesting. I've been trying to think this through, and I've seen people have conversations or whatever it's called on places like Twitter, where people will say, well, I would just sort of, not the specific situation, but just sort of dismiss that patient in a sense of not engage with that. And I don't think that's the right answer, but I don't know what the right answer is. And I obviously think a lot about interdisciplinary and intercultural kind of work.
Well, from an educational standpoint, is this a thing that you could feel comfortable talking to your residents and the medical students about and saying, look, I don't know what the right answer is here. What do you think?
Yeah. And I think we didn't ever have time to do it while I was working with them, but as it's like that moment when you think of the perfect thing to say, 10 seconds after the conversation happens.
Right.
In retrospect, I wish I would have taken the team aside and just said, I don't know how to handle this situation, but I feel this tension between helping this person at the same time as I feel the need to not validate their worldview, at least to the team that I'm caring for.
Is it possible? And I don't mean to, I don't know. I don't want to overspeak or anything, but is it possible that also in those kinds of moments, a solution or even, fixing it, is maybe not necessarily even what that patient or another patient would even want, as much as maybe just someone to just listen. And so, and by doing so, you just listening, maybe that makes that person feel validated, but also you're not having to, you're not having to necessarily provide some sort of solution to something that you either don't feel comfortable providing a solution to, or don't necessarily believe that there's, something that necessarily should be fixed, I guess. I feel like it kind of comes down to empathy too in that moment, where again, you're not, I don't know how to phrase this, but it's like you're not necessarily trying to fix anything as you are just there to just be a person that makes that other individual, the patient, just feel like they were at least heard.
Yeah, you're just trying not to judge them.
Right.
Yeah. And I think I can do the neutral, non-judging thing pretty well. I feel comfortable with that with everything I've been through. It's how you help them work through a problem that I think their value construct is fundamentally different.
Right.
Yeah.
And I can't even agree.
When I would say fundamentally flawed. But
Yeah.
it's interesting. I heard I was observing a medical class one time, and there was a student who said that they it was back when we were all discussing whether or not someone should be forced to bake a cake for a same-sex couple or something like this. And so it was on people's minds. And one of the students said that they weren't comfortable treating people in same-sex marriages, and the medical educator said, then get out of this field. This is not the job for you. And you can say that to a student because this is not the job for you. But you're dealing with a patient, which is a different, like you can take a, you know what I mean? You can lay down an absolute value system. This is the right thing to do. This is the wrong thing to do. But you're talking about a patient that you're not supposed to be judgmental, and it's not clinically good to be judgmental.
Yeah. Well, I actually wouldn't agree with that educator that says, "Get out of this room. This isn't the field for you."
Yeah. I thought it was genius.
Well, I think it's easy to sort of dismiss and to other the people, but I think in that situation, you sort of try to explore what's going on there, but people change how they view the world. And so, same-sex relationships are a great example of this, or the transgender movement. I mean, we have very quickly gone through understanding different gender and sex identities and roles in this country much faster than we figured out race or women versus men's rights and things like that. And that's amazing. It's just tremendous that we've been able to do it so quickly. And I don't begrudge the person that takes a little bit longer. Like, I didn't understand the pronoun thing for a while. It took me a while to understand it. And then I was like, okay, I get it. So
your theory is that this person will eventually catch up with the world, but at the moment they're struggling.
My theory is that we need to give them a chance, particularly if they're a learner, to try to catch up with the world.
It's interesting because having been in theater for so long, this is not these are settled issues. This is not a thing that anyone should be discussing anymore. And it is interesting to me that it is still an issue, a strong issue for some people outside.
Yeah. Well, and I think if we become too absolutist, we give up on people. And part of interdisciplinarity is to sort of say, okay, let's try to find that common place in our differences and understand what we might be able to create out of it. And it's more neutral territory to talk about it as professional fields, but I think there are different cultural ways of thinking about things. And I think we all know people that were somewhat prejudiced, bigoted in some way, and became less prejudiced and bigoted in some way.
What's the saying that the arc of the moral universe is long, but it bends towards justice? So that's interesting. You just did a really nice thing of sort of tying interprofessionalism back into this other thing, which is a nice wrap up, and we should probably end around here. But I think the lesson that I'm hearing is that it's okay to not know the answer.
Yeah.
It's all right to sit in your. I think you're a very good doctor, very good teacher. You're a very good person, Alan.
Mm-hmm.
And the fact that you didn't know the right answer and still don't know the right answer, I think is hopeful, because I think maybe we don't. I asked you a bunch of questions at the beginning, and you were kind enough to answer about the COVID pandemic and about what lessons we could draw from interprofessionalism, and you're very good at making connections. And yet, we're talking about interdisciplinarity, and we're talking about now you've just broadened it to interculturalism.
Yeah.
And and maybe we don't know. That is interesting.
And I also think that just goes back into who you are, Alan, but also just the frame of mind that it does take to be an interdisciplinarian. I mean, is that the right word that I'd want to use for that moment, though? An interdisciplinarian? Is that right? That doesn't seem right.
That doesn't seem right.
That doesn't seem right at all.
I think it sounds great.
It does sound great.
But you know what I mean. But like, a leader is somebody that does not have to provide necessarily certainty as it is perhaps clarity. And if the clarity that you can provide to either the patient or to the rest of your team is, this is a moment that we're all still learning from and that we're still going to evolve from, and that's okay. I think sometimes that's all that does matter, is the fact that this is a gray area, and instead of pretending like it doesn't exist, very much recognizing that it does exist, and this gray area will make us better. We'll learn from this. We'll learn from each other. We'll learn from other cultures. We'll learn from other systems. And that's what makes a good leader. That's what makes a good healthcare provider, I think.
Be comfortable with uncertainty?
Yeah, I think so.
The Reinvention podcast, making you dumber every day.
All right. Alan, thank you so much. We got really deep really at the end there. So go to reinventionpodcast.com for free resources. Alan, thank you very much for being here.
My pleasure.
Thank you, Alan.
Thank you.
All right, guys. I'm going to hit the off button here, I think.